Imagine you have this perfectly tailored suit jacket. Like it fits you flawlessly, but there's this massive ragged hole right on the lapel.
Oh, that's a nightmare scenario right there.
Right, and to fix it, you have to cut a piece of fabric from the inside lining and move it to the front. But now imagine that jacket is a human face.
Which completely changes the state.
Exactly, and you're not just using thread to stitch a lifeless patch. That borrowed piece of fabric, it has to stay alive, it has to bleed, it has to heal, and it has to function perfectly in its highly visible new home.
Yeah, you can't just slap a patch on it and call it a day.
So how do surgeons even begin to solve a puzzle like that? Welcome to today's deep dive, where we're decoding the hidden architectural marvels of the human body. We're looking at some excerpts from otolaryngology, head and neck surgery, and exploring the wild ways surgeons borrow tissue.
It really is like the ultimate three-dimensional logic puzzle. When a surgeon is looking at a significant defect on the head or neck, maybe from a trauma or after removing a cancer, they aren't just trying to plug a hole.
Right, they have a lot more to worry about.
Exactly. They are balancing this incredibly complex set of demands. The first is appearance, what surgeons call cosmesis, because this is a person's identity, it's their face.
Yeah, that's what the world sees.
But equally critical is function. The tissue they move has to actually allow you to eat, to speak, to blink, to swallow, and before they even pick up a scalpel, they have to navigate the patient's entire medical reality.
Well, yeah, because you can't just focus on the hole in the lapel if the rest of the jacket is falling apart. There has to be a baseline of health to even attempt something this complex.
That's a great way to put it. There are what we call absolute contraindications. Basically, situations where complex reconstructive surgery is just, well, it's completely off the table.
Like what kind of situation?
So, if a patient comes in with an untreated pneumothorax, like a collapsed lung, you absolutely cannot put them under for a massive multi-hour surgery. Their body simply cannot handle the stress.
Right, that makes sense. They wouldn't survive the anesthesia.
Exactly. Or if they are currently taking heavy chemotherapy drugs, like cisplatin or doxorubicin, those drugs are designed to stop cell division to kill cancer, right?
Which is great for fighting the tumor.
Yeah, but that means they also completely destroy the body's ability to heal new tissue. You'd just be setting the patient up for catastrophic failure. The wounds literally wouldn't close.
Okay, so assuming the patient is relatively stable and healthy enough for surgery, the surgeon still isn't just winging it, right?
Oh, definitely not.
Yeah.
There's a very specific philosophy they follow. It's a framework for making decisions called the reconstructive ladder.
The reconstructive ladder. Okay, so how does that work in practice?
Well, it's the guiding philosophy of the entire field. Surgeons approach every single wound by mentally climbing this ladder. They start from the absolute simplest solution, and they only move to more complex, risky procedures if it's absolutely necessary.
Let's walk up that ladder. What is the absolute simplest solution? Like just putting a band-aid on it.
I mean, essentially, yes. Step one is called secondary intention, which is really just a fancy medical way of saying let the body heal it on its own.
Wait, really? Just leave a hole there?
Yeah, you just keep the wound clean and let it close up naturally from the bottom up. And this actually works beautifully for small defects in concave areas, like the inner corner of the eye.
Oh, because the natural shadow kind of hides any minor scarring?
Exactly. The anatomy does the work for you. But, if the hole is too big to just scab over, you have to move up a rung on the ladder.
Okay, so what's rung number 2?
Step 2 is primary closure. That's simply pulling the two edges of the skin together and sewing them shut, like a standard stitch.
Right, but what if you can't pull the edges together without totally distorting the face?
Then you go step 3, which brings in skin grafts. That's where you shave off a super thin layer of skin from somewhere else, like the thigh, and lay it over the wound.
Just laying it on top.
Yeah, but grafts are thin. They don't have their own blood supply, so they just have to absorb nutrients from the wound bed underneath. So if you need actual bulk-like muscle or fat, you go to step 4, local skin flaps.
Which is where you cut into the adjacent healthy tissue and sort of stretch or rotate it over the defect.
Spot on. But if you don't have enough local skin to stretch, you go to step 5, which is tissue expansion.
Oh. I've actually seen this. This is where they put a little balloon under the skin near the defect and slowly inflate it over weeks, right? To literally grow more skin.
Precisely. Creates a bank of extra tissue that you can use later. It's really clever. But if the local tissue is totally ruined, maybe from radiation therapy, cooked tissue, you move to step 6.
Which is?
Regional pedicled flaps. This is where surgeons borrow massive blocks of muscle and skin from farther away, like the chest or the back.
And they just swing them up to the head.
Exactly, while keeping them attached to their original blood vessels. And finally, if that won't work, you hit the top of the ladder. Step 7, free tissue transfer, or free flaps.
This is the microsurgery stuff, right?
Yes. You completely detach a piece of tissue, say a chunk of your forearm, move it up to your jaw, and reconnect its tiny blood vessels under a microscope.
Okay, wait, let's unpack this for a second. If a free flap is the absolute pinnacle of modern surgical technology moving bone and muscle and reconnecting it microscopically, why not just use the best tech right away?
I get that logic. It seems like you'd want the premium package.
Yeah. If I have a defect on my face, I want the most advanced option. Why climb the ladder at all? Why not just jump straight to step 7?
Because in surgery, complexity always brings risk. Every single time you move up a rung on that ladder, you are increasing the time the patient is under anesthesia.
Which is dangerous in itself.
Very. And you are increasing the damage to the donor site where you took the tissue. Plus, you're drastically increasing the sheer chance of catastrophic failure.
Because there's more that can go wrong with the microscopic stuff.
Exactly. If a microscopic blood vessel clots in a free flap, that entire piece of borrowed tissue dies. It's called necrosis. You lose everything. The flap fails, and you're back to square one, but with a sicker patient.
Oh, wow. So you really don't want to overcomplicate things if you don't have to.
Right. The guiding principle for these surgeons is elegance through simplicity. The simplest, least invasive option that effectively restores form and function is always the safest. Less really is more.
That makes perfect sense. You don't use a sledgehammer to crack a walnut.
Exactly.
But, to even move tissue up that ladder, whether it's stretching a local flap or swinging a massive muscle from the chest, we have to understand the single most important rule of the game.
Which is keeping the borrowed tissue alive.
Exactly. We need to talk about the hidden plumbing of the human body.
The vascular anatomy. This is where the sheer engineering of the human body truly shines. To understand how surgeons move tissue, you have to understand the angiosome theory.
Angiosome theory. What is that exactly?
It's this revolutionary way of mapping the body. It essentially divides human anatomy into 40 distinct three-dimensional blocks of tissue.
Like a grid.
Yeah, like a three-dimensional grid.
Sure.
Each one of these blocks, these angiosomes, includes the skin, the fat, and the underlying muscle. And it is entirely supplied by its own specific named source artery.
It's literally like a power grid. And the way this blood actually reaches the surface of the skin dictates exactly how a surgeon can cut and move it, right?
Yes, and there are two main types of blood supplies we need to talk about. First, you have what are called musculocutaneous vessels.
Which are the tiny ones.
Right. These tiny vessels run perpendicular to the skin, they come straight up from the deep muscle, and branch out into this tiny web right under the skin surface. This is the basis for what surgeons call random flaps.
Right, random flaps. And because they rely on that tiny diffuse web of superficial vessels, they have strict limits, don't they?
Very strict. You generally can't make a random flap longer than 3 times its width.
Because if you make it too long, what happens?
That tiny web just can't push the blood all the way to the tip. The tip gets starved of oxygen, turns black, and dies.
Yikes.
But then you have the second type of blood supply, direct cutaneous vessels. These are the absolute game changers.
Because they run parallel to the skin, right? I love visualizing the difference between the two, because a random flap is basically like a lawn sprinkler system.
Oh, that's a good analogy.
Right, like a sprinkler shoots water straight up, it waters a general area broadly, but weakly. You can't just attach 10 hoses to a sprinkler head and expect the pressure to push water 50 feet away.
Right, the pressure just isn't there.
But a direct cutaneous vessel is like a dedicated high-pressure garden hose connected straight to a specific heavy-duty faucet. You can pull that hose a very long distance, and you know exactly where the water's flowing.
That garden hose analogy is spot on. Surgeons use that hose to create what are called axial flaps. They literally dissect out that specific named artery. artery and the vein that drains it.
And because they have that main pipe, they can move a lot more stuff.
Exactly. They can safely move a massive amount of tissue because they know the main pipe is fully intact. And because of those robust direct vessels, the variety of tissue surgeons can harvest is just astounding.
Yeah, reading the sources, it's not just skin they move.
Oh, not at all. They move bone. They will take the fibula, which is the smaller bone in your lower leg, along with its artery, and they use it to rebuild a shattered jaw.
That is crazy to think about, taking your leg bone to make a new jaw. And it gets wilder than bone. They do visceral flaps too.
Yeah, this is where it really sounds like science fiction.
Surgeons will literally take a piece of your digestive tract, like a section of your colon or your jejunum, and move it up into your neck.
It's incredible. If a patient has their throat removed due to cancer, they use that piece of intestine to rebuild the pharynx and esophagus.
Just so the patient can swallow again.
Yeah, and it is brilliant because the intestine is naturally tubular, right?
Yeah.
And it naturally produces mucus, which perfectly mimics the environment of the human throat.
It's pure bioengineering.
It really is.
Yeah.
But as complex as that is, we haven't even touched on the most remarkable part of this plumbing system, innervated flaps.
Oh yes. This is where they aren't just hooking up the pipes so the tissue lives, they're actually rewiring the electrical grid so the tissue can feel.
Exactly. They restore sensation.
This blew my mind. Tell me how this works with, say, a tongue reconstruction, because that sounds impossible.
Okay, let's say a patient has a partial glucectomy. A large tumor is removed from their tongue. To replace that bulk, the surgeon might harvest a free flap from the patient's radial forearm.
So they take skin and fat from the arm.
Right. But a totally numb block of tissue in your mouth is really dangerous. You could bite it or burn it with hot food without even knowing.
Ouch. Yeah, you need to feel your tongue.
So when the surgeon harvests that forearm skin, they intentionally dissect out the nerve that supplies it, the lateral endobrachial cutaneous nerve.
They take the nerve with the skin.
Yes. And when they move that tissue to the mouth, they microscopically sew that forearm nerve directly into the stump of the patient's lingual nerve.
Which is the nerve that normally gives feeling to the tongue.
Exactly. They splice the arm wire into the mouth wire, basically.
Wait, okay, so if the patient touches a hot cup of coffee to their new tongue, do they feel it in their mouth? Or does their brain think their forearm is getting burned?
Well, actually, at first, the brain might misinterpret the signal and think the forearm is being touched.
No way!
Yeah, but the human nervous system is incredibly plastic. Over time, the brain maps that new tissue to the mouth. The patient actually learns to feel that piece of arm skin as their own tongue. They completely regain sensory awareness in their mouth.
That is just astonishing. Okay, so we've got the philosophy of the ladder, and we understand plumbing and the electrical grid. Now let's zoom in on the canvas where a lot of this incredibly precise work happens.
The face.
Yes, the face. When you are moving tissue on the face, there is zero room for error. You can't just cut and pull. You have to follow strict geometry.
Absolutely. And the first rule of facial geometry is mapping the natural geography of the skin. Surgeons orient their cuts to what are called relaxed skin tension lines, or RSTLs.
Which are what? Exactly.
If you pinch your skin or just look at your natural wrinkles, you're seeing these lines. They are the natural micro creases created by the muscles underneath.
And the rule is, if you cut across them, like perpendicular to the crease, the healing skin pulls apart and you get a wide, obvious scar.
Exactly. But if you hide your incision parallel to them, right inside a natural wrinkle, the scar practically vanishes when it heals.
But when you start actually sliding flat skin around to cover a hole, you immediately run into a three-dimensional geometric problem, right? The dog ear.
Oh, the dreaded dog ear. Think about trying to sew two unequal sides of a circle together. The extra skin has nowhere to go, so it bunches up the ends into these little standing cones of tissue.
And to fix this, surgeons use an origami-like technique called Burroughs triangles.
Yes, they do.
Wait, I need to make sure I understand this. To fix a hole, the surgeon actually cuts more healthy skin out of the patient.
I know it sounds counterintuitive, but yes. They intentionally cut tiny triangles out of the healthy skin right at the pivot points of the flap.
And that helps.
Massively. By removing those specific wedges, it allows the entire patchwork to lay perfectly flat against the skull without puckering. It's pure mathematical precision.
Wow. And that math gets even more intense when we talk about transposition flaps.
Oh, yeah.
These are the flaps where you don't just slide tissue forward, you literally lift a patch of skin and pivot it over a bridge of healthy tissue to drop it into a defect.
Right, and the textbook example of this is the classic rhomboid flap, also known as the Limburg flap. It is mathematically beautiful. The surgeon cuts the flap into a very specific diamond shape, using 220-degree angles and 260-degree angles.
Why the specific angles? Like, how does making a diamond shape help anything?
It's all about redirecting tension. When you sew a wound shut, the skin naturally pulls back. If the tension is too high, right over the original defect, the wound will literally rip open, or the tissue will choke and die. So by using that exact 120-degree and 60-degree geometry, the surgeon mathematically distributes the pulling force completely away from the fragile healing tissue.
So it shifts the stress.
Exactly. The point of maximum tension gets shifted onto the healthy, stable surrounding skin.
That's incredible. And they also use optical illusions to hide the seams, right? Like the Z-plasty.
Yes, Z-plasty is this brilliant camouflage technique. It doesn't move massive blocks of tissue. Instead, if a patient has a long, straight, contracted scar, which the human eye is naturally drawn to, the surgeon cuts a Z shape right through it.
And then what?
They lift the two little triangular flaps created by the Z and swap their positions. This breaks up the straight scar into an irregular zigzag pattern that falls naturally into the skin's tension line.
So it basically tricks the eye into ignoring the scar. Okay, the geometry is genius. But we have to talk about the interpolated flap, specifically the paramedian forehead flap. When I was reading about this in the source text, I legitimately had to pause.
It's definitely a striking procedure.
So let's say someone loses a large portion of their nose to skin cancer. You can't just stretch cheek skin over it, right? It wouldn't look right. You need skin that matches the exact color, texture, and pore size of the nose.
And the forehead is the perfect match for that. It is the absolute best donor site for nasal reconstruction.
But the cartilage of the nose doesn't have strong enough blood supply to keep a random free-floating graft of forehead skin alive, right? It needs that garden hose blood supply we talked about earlier.
Exactly.
So the surgeon cuts a flap of skin from the forehead, but they don't cut it completely off. They leave it attached at the eyebrow where a major artery is pumping, and then they twist that flap down over the eyes to cover the nose.
Yep, that's the procedure.
But what happens to the connection? Does the patient just have a bridge of flesh connecting their forehead to their nose?
They do. It is a literal bridge of tissue bridging over healthy skin.
You're kidding.
No, I'm serious. That pedicle acts as a biological umbilical cord. It is pumping warm, oxygenated blood from the forehead down into the healing nose reconstruction.
So they just walk around with a trunk of flesh down the center of their face for how long?
For about 3 to 4 weeks.
Oh my gosh.
I know it sounds jarring, and it is a heavy psychological burden for the patient to live with that facial scaffolding. But during that month, the new skin is slowly establishing microscopic connections with the nose bed.
So the nose is adopting the tissue.
Exactly. The nose is literally growing its own new blood supply into the flap. And once the tissue has completely rooted itself and no longer needs the forehead artery, the surgeon goes back in, simply snips the bridge, sews the nose down seamlessly, and returns the little unused portion to the eyebrow line.
That is wild.
It requires immense patience, but it produces a nose that looks entirely natural.
It's literally the body rerouting its own life support system. But, you know, everything we talked about so far, the lingual geometric flaps, the forehead bridge, these are mostly for the face, for relatively manageable spaces.
Right, localized defect.
What happens when a surgeon encounters massive destruction? Say a patient had a huge tumor removed from their neck, and the entire area was bombarded with high-dose radiation.
Oh, that's a totally different ballgame.
Because the local blood vessels are fried, right? You can't use local tissue at all.
Exactly. When you reach that level of damage, local flaps just fail. The irradiated tissue is like dry desert soil. Nothing will grow there. You have to import healthy, vigorously vascularized tissue from outside the blast zone.
You need heavy lifters.
You really do. This is where we look to regional pedicle flaps. These bring their own major named blood supply from completely different parts of the body.
And the undisputed king of the heavy lifters is the pectoralis major flap, right? The chest muscle.
Yes, it is the workhorse of head and neck reconstruction. It brings a massive block of muscle and skin, powered by a huge artery called the thoracoacromial artery.
But how do they get a piece of your chest up to your face? Do they just leave a trench on the outside of your body?
No, it's all done internally.
No.
The surgeon elevates the skin of the chest and the neck, creating this subcutaneous tunnel. They cut the pectoralis muscle from the ribs, but leave it tethered to its artery near the collarbone.
Okay.
Then they pivot the entire muscle up, pass it under the skin of the neck, and use it to rebuild the inside of the mouth, or the throat, or the jaw.
But wait, if you take skin from the outside of a patient's chest and you flip it up to rebuild the inside of their mouth, what about hair?
Yeah, that is one of the bizarre, very real compromises of this surgery. If you use hairy chest skin to rebuild the tongue or the inside of the cheek, the patient will literally have hair growing inside their mouth.
Waking up with chest hair in your mouth, that is intense.
It really is. Surgeons try to select non-hairy areas, or they rely on the fact that the wet environment of the mouth often suppresses the hair follicles over time, but it is a known risk.
So if the chest isn't ideal or if it's too bulky, where else can they pull from?
The latissimus dorsi is another marvel. That's the massive V-shaped muscle on your back.
Your back.
Yeah, and it is supplied by the thoracodorsal artery, which has an incredibly long leash, up to 15 centimeters of free blood vessels before the muscle even starts.
From the back to the head, how does that even physically work without looking like a massive bulging lump under the skin?
Because that 15 centimeter leash gives the surgeon incredible reach. They can tunnel that muscle all the way from the back, under the armpit, up through the neck, and reach all the way to the top of the scalp to cover a massive defect.
That's amazing.
And because it's a broad, flat muscle, it actually drapes beautifully. Plus, the back is far away from the radiated field of the neck, and it generally transfers less hair than the chest.
Okay, but this brings us back to our earlier question about the reconstructive ladder. Right.
We talked about free flaps earlier, where you just disconnect the tissue entirely, plug the tiny vessels in microscopically, and avoid tunneling muscles up the neck altogether.
Yeah, the top rung of the ladder.
Right. If regional flaps are so bulky, and they require these massive tunnels under the skin, why are they still such a critical part of a modern surgeon's toolkit? Why not always just do a free flap?
Because we have to remember the human element. Free tissue transfer is miraculous, but it is deeply demanding. It requires highly specialized microsurgical training, dedicated equipment, and an operation that can easily last 10, 14 hours.
And not every hospital has that.
Right, not every hospital in the world has that capability. And more importantly, not every patient can survive a 14-hour anesthesia.
Like the patient we talked about earlier with the collapsed lung, or an elderly patient with severe heart disease.
Exactly. For those patients, a regional pedicled flap is a literal lifeboat. You don't need a microscope. You aren't gambling on tiny vessel connections.
You're just swinging it up. Yeah, you are just swinging a robust, reliable muscle on its natural existing artery. It might only take 3 or 4 hours. It might be a bit bulkier. It might not be the absolute pinnacle of cosmetic perfection, but it reliably closes the wound, it covers the exposed vital organs, and it saves the patient's life.
They are the heavy-duty safety net when everything else falls apart.
Well said.
Okay, let's pull all of this together. We've gone on an incredible journey today. We started with the careful, calculating philosophy of the reconstructive ladder, the wisdom of knowing when a simple stitch is better than a 10-hour surgery.
Right.
We mapped the plumbing, looking at how the body is divided into 40 distinct power grids called angiosomes. We dug into the 120-degree mathematics of the face, bending geometry to hide scars and stretch tissue.
Pure math.
And we looked at the massive scale of the heavy lifters tunneling muscle from the back all the way to the top of the head. So if you take anything away from this deep dive, let it be this. Beneath your skin lies an invisible, highly structured master plan. Your body isn't just tissue. It is a living, breathing architecture waiting to be repurposed.
It truly is. And, I'd like to leave you with a final thought to ponder.
Oh, please do.
Throughout this discussion, we've explored how surgeons act as master carpenters, navigating this architecture to borrow and shift tissue. They take from the chest to fix the neck, or they build a bridge from the forehead to rebuild the nose.
Yeah, it's brilliant.
It is. But it is always a game of borrowing from Peter to pay Paul. There is always a cost to the donor site.
Right, you're always leaving a scar somewhere else.
Exactly. But looking ahead, as our technology merges with this biological map, what happens when surgical architecture collides with the future of bioprinting?
Oh, wow.
Will the reconstructive ladder of the future completely eliminate the need to borrow tissue at all? Will we eventually reach a point where, instead of harvesting a flap from your forearm and rewiring its nerves, we simply load your own stem cells into a printer and print a brand new, fully vascularized puzzle piece from scratch?
The ultimate primary closure. A bespoke, laboratory-grown patch for that tailored jacket, printed entirely on demand. No borrowing required. That is definitely something to think about the next time you look in the mirror. Thanks for joining us on this deep dive. Keep learning.